Please welcome Dr. Alison Behrman.
Thank you. Thank you, Jennifer. Jennifer, did you notice all of the extra security that was here for my presentation? I mean, I knew I was important, but this is great. Hi, everybody. I'm Alison Behrman, and I am absolutely thrilled to be here. Or as my 20-something-year-old daughter would say, it's just awesome. It's just awesome. Of the speech-language pathologists in the room, can I have a show of hands? How many of you have experience working with adults with Parkinson's disease? Fabulous. Okay. And of the speech pathologists in the room, how many of you are trained in LSVT? Terrific. And how many of you are trained in speak out and or loud crowd? Outstanding. Okay, so there is a tremendous amount of clinical expertise in this room, a great base upon which you will build your knowledge to gain even greater expertise, to be even better speech-language pathologists working with adults with Parkinson's disease. And just like the security had nothing to do with me, so too the therapies that we administer, that we direct, are not about us. They're about our patients. They're about bringing greater joy into the lives of our patients with Parkinson's disease by helping them to be more effective communicators so they can do what they want, so that they can live life, so that they can be joyful. And that's what we're here to learn more about over these next couple of days. Making our bed in the morning, and then doing really good therapy and living our lives with intent. Next slide. So the required disclosures for CEUs, back one, please. Thank you. So I am a very proud member of the Scientific Advisory Board of Parkinson Voice Project. I get an honorarium for this presentation. I got my travel and hotel paid for. But probably the most exciting thing to this New Yorker is that I'm going to get fed a real Texas-style barbecue today. And that's really exciting me. Thank you. All right, next slide. So this is a sophisticated crowd, and you do understand the basics of the physiology of Parkinson's disease. But in order to fully understand speak out and loud crowd therapy and approaches, you need to take a little deeper dive to really understand the pathophysiology of Parkinson's disease and its impact upon speech production and your therapy. In particular, the role of the basal ganglia in habitual and goal-directed motor speech activities, habitual and goal-directed speech production. Next slide. So we know that the speech motor system is controlled by the direct and the indirect cortical motor pathways. Speech pathologists, take your memory back to your neuroanatomy class in grad school. I know it was one of your favorite classes. And what you can see, what you know, is that the direct motor pathway goes from the cortices directly down to the brainstem lower motor neurons, the cranial nerves that control the muscles of speech production, and that the indirect cortical motor pathways, the basal ganglia, the cerebellum, back through the thalamus, provide feedback to the cortices, which then influence the direct motor pathway. If there is dysfunction in basal ganglia, the body can't just say, okay, forget it, I'm not going to take that route, I'm just going to use the direct motor pathway. Neurons don't work that way because that direct motor pathway gets input from the indirect motor pathways. Next slide. So we know that in Parkinson's disease, we know that it's a neurodegenerative disease involving multiple motor and non-motor circuits. And it's characterized by two major pathologic processes. One is the loss of dopamine, particularly in the substantia nigra, and the other is the accumulation of Lewy bodies. Lewy bodies are misshapen proteins that contribute significantly to neuron cell death. And early in the disease process, these Lewy bodies accumulate in the brainstem, particularly around olfactory nerve neurons, which is why so many patients with Parkinson's disease report that their first symptoms are loss of sense of smell. And then as the disease progresses, these Lewy bodies do start to proliferate in the limbic regions, which control emotion and motivation, and in cortical brain regions, particularly cognitive and motor areas. The loss of dopamine in particular results in muscle rigidity and bradykinesia, slowness of movement. And this we as speech pathologists learn in our motor speech disorders in class. Next slide. The traditional hypothesis is that the rigidity and the bradykinesia are the primary driving factors of the hypokinetic dysarthria. The reduced loudness, the reduced prosody, the reduced articulatory precision, the slow initiation of speech. Over the past 2 decades, there has been an explosion of information about basal ganglia. And that has modified our thinking about the physiology of hypokinetic dysarthria that heavily influences our speech therapies today, and particularly speak out and loud crowd therapy. So what I want to do right now is zoom in a little bit more closely to basal ganglia. Next slide. So this is a simplified diagram of the basal ganglia. We have the cortex on top, all of the basal ganglia output to the thalamus, which then goes mainly back to cortex. Basal ganglia are just an accumulation of neural cell bodies. The functional model of the basal ganglia from the late 1980s was a strict division of the basal ganglia into a direct and an indirect pathway. We're not talking about the cortical motor direct and indirect pathways. These are direct and indirect pathways within basal ganglia. And so you can see that the direct pathway, I don't have access really to a pointer, but the direct pathway with input from substantia nigra pars compacta, dopamine inputs into the striatum. The direct pathway goes directly to the globus pallidus, internal, which then outputs to the thalamus. The direct pathway is mediated by D1 receptors. Those are excitatory receptors. And so the D1 direct pathway, a monosynaptic pathway, goes to the thalamus and release, because it's excitatory, it allows the thalamus to release the cortex from inhibition. And so it's excitatory. The indirect pathway going from striatum to globus pallidus external subthalamic nuclei down to globus pallidus internal and back to thalamus is mediated by D2, which is inhibitory. And what the indirect multisynaptic pathway does is it exerts an inhibitory control on thalamus, which then exerts greater inhibition on the cortex. So it quiets down the cortex. So the polysynaptic indirect pathway stimulates tonic inhibitory control. Tonic control meaning normal background functioning. So it quiets down cortex. And I've had more than one student in my grad classes that thinks that my indirect pathway doesn't work well enough because I get a little too wired. The monosynaptic direct pathway produces phasic signals. What is phasic? Sensory evoked activity for goal-directed behaviors. The monosynaptic direct pathway excites the cortex. So in a healthy state, activation of indirect circuits promotes movement inhibition. Activation of the direct circuits facilitates movement. It's a careful balance. When I am speaking to you, I am speaking with intent. I am using goal-directed behavior, but not 100%. I don't have to think about all of the movements of my mouth. I don't have to think about my whole speech production system. So there is some automatic behavior going on. And that automatic behavior will vary over the course of my presentation with the goal-directed behavior, depending upon exactly what I'm saying, how much I want to emphasize a point, how much I get carried away and start talking too fast. When after this presentation I'm enjoying my Texas-style barbecue and I'm chatting with you individually, then it's going to be much more automatic behavior and much less goal-directed behavior. In Parkinson's disease, loss of dopamine most seriously affects the D1 receptors. Thus, activation of the direct activation pathway is reduced, and the indirect pathway is facilitated. Thus, inhibition is in overdrive. Now, this direct and indirect pathway model is a little old. It still is valid, this part, which was worth discussing, but the more current model of the basal ganglia is just a bit more complex. Okay, so your first impression of this slide should be, thank God you're not in one of my neuro classes. There is no midterm and final, I promise, okay? Although Samantha may be quizzing you on the way out. The first thing you should note is more red lines. Red lines, red arrows, that represents dopamine. There is, in fact, the research shows there are substantially greater dopamine pathways in the basal ganglia, not just going to striatum, but to the other ganglia, as well as directly back to cortex. And note that while the direct and the indirect pathways are still present, there are a lot more interconnections in the basal ganglia than was first hypothesized. So what this means is that it's a little bit more difficult to predict movement outcome based upon any sort of dysfunction within any parts of the basal ganglia, as well as there's a lot greater potential for adapting pathways in the basal ganglia when there is dysfunction. And I know that perks up the ears of the speech-language pathologist because that is what we are taught in our therapies. That is what we are trying to do. We're trying to maximize and create new pathways, alternative pathways that can take advantage of the function and limit as much as possible the dysfunction. But here's the other very important piece of information about the basal ganglia that is really coming out of current research that isn't shown in this slide at all. And that is that it is recognized that the basal ganglia are subdivided anatomically into functional domains that have topographically organized connections to external structures. This is the point in my class where my students say, Dr. Behrman, can you please say that again 500 times? All right. Topographic organization. What is topographic organization? That means that different areas of the individual ganglia subserve different functions. There are three major functions that have been identified recently in this topographic organization. One is emotional, limbic system, motivation and emotion. The second is associative, cognitive. And the third topographic function is sensory motor. Next slide. So what we're going to do is reimagine the basal ganglia now, not as the individual ganglia and their connections, but we're going to focus now on the functional domains of the basal ganglia, specifically the sensory motor and the associative cognitive domains. We're leaving out limbic just because it's too complicated to put in a slide. The associative basal ganglia circuits on your left originate predominantly in the dorsomedial striatum and include predominantly frontal cortex connections. These circuits are heavily involved in goal-directed behavior, the associative basal ganglia circuits. The sensory motor basal ganglia loop on your right originate largely in dorsolateral striatum, particularly posterior putamen, and include predominantly connections to the sensory and motor cortexes. These circuits are concerned mainly with stimulus response habitual movement. Next slide. In Parkinson's disease, the primary area of loss of dopamine is in the posterior putamen, and that's the topographic area for habitual control of motor movement. Thus, automatic functions are reduced in speed, in amplitude, and in accuracy. Activity in the dorsomedial striatum, the area associated with goal-directed behavior, that activity remains relatively preserved. Thus, the loss of function in the habitual domain means that there needs to be an increased reliance on goal-directed control to maintain quality of output. If you take nothing away from this talk except this statement, take that away. The loss of function of the habitual domain means that there needs to be an increased reliance, increased vigilance on goal-directed behavior. But that's not to say that, the habitual control loop is impaired, and so we're just going to focus on goal-directed behavior. Rather, it's more difficult than that. The impaired habitual control functional domain provides distorted output, so that the goal-directed behavioral control needs to compensate for the distorted habitual control. Otherwise, the distortion occurs in scaling of output, in effort, and in output gain. Next slide. So if we return now to this first slide that showed the direct and the indirect motor pathways from the cortex, I want to emphasize here the two big black downward arrows from brainstem reticular formation to lower motor neurons to muscle, because we need to remember that it is the sum the sum total of all inputs from sensory, all outputs from motor that go down ultimately to the final common pathway to the cranial nerves that control speech motor control. It is the sum total, both the distorted, the impaired habitual control, as well as the relatively preserved goal-directed control. Thus, it's not a matter of just using the goal-directed pathways instead of the habitual loops. It's that the goal-directed pathways must overcome the impaired habitual circuits. Movement effort must be scaled up, and the somatosensory processing must be recalibrated. And that is your job as speech-language pathologists, to achieve that. All right. So what does this mean for speech-language pathologists working with individuals with Parkinson's disease? Well, in order to answer that question, we need to put this information into the larger context of speech production. And I know I'm pushing the envelope here a little bit in terms of the neurophysiology, but I want you to get an idea here of the level of complexity of Parkinson's disease processes and the level of complexity in which speak out and loud crowd are grounded. So I want to take just a very brief look here at an innovative model of speech production that drives a lot of research in typical and atypical speech production, and I think it'll help clarify things even further. Next slide. There are models called the DIVA and GO-DIVA models of speech production, which are the current hot theories of speech motor control. Bless you. You may not read about them on the front page of the Times, but you'll read about them on the front page of your motor speech disorders articles. All right. These models originate with Frank Gunther and his colleagues. They're cognitive neuroscientists and engineers in the labs of MIT and Boston University. We're talking about smart guys here. All right. Directions into velocities of articulators, the DIVA model, very, very brief overview. It's a neural network. It describes sensory motor production that's involved in articulator control, movement of the articulators in speech production. And this theory has helped to explain such phenomenon as motor equivalence. How come three of us in the room use three different ways to produce the same sound, all right? Anticipatory and carryover articulation. Why do our phonemes change just slightly depending upon the sound before and the sound after we're producing? These models help explain the velocity, the speed and the direction of the relationships of the articulators, how fast or slow the tongue or the jaw or the lips have to move for a given sound in connected speech. These models help explain the effect of speaking rate, speaking too fast or speaking too slowly, how that distorts speech. And these models have helped guide research in fluency disorders and apraxia of speech, the role of auditory feedback in normal hearing and hearing impaired, and are also starting to guide models of research in Parkinson's disease. So just to back up for 1 second, when we're talking about a model, what are we talking about? I mean, we're not talking about the model walking down the runway. What we're talking about is basically a series of mathematical equations in a computer program. And these equations are set to certain variables, and they output to an actual physical piece of equipment that can generate speech sounds, mainly vowel sounds. And then these vowel sounds are input back into the series of equations with acoustic analysis, and these series of equations determine whether the vowel output was correct or not, and if it's not, the equations adapt their values and modify the directions to this instrument that produces a different sound. Well, this is indeed what the brain does using feed forward and feedback control. And the values for these equations come from functional magnetic resonance imaging studies, PET scan imaging studies that show different metabolic activities of the brain, what areas of the brain are active during which functions. All right, so this is a very simple diagram. I don't need to really explain this very much. Okay, all right. No test on this, folks, no test. All right. What I want you to focus on in this diagram is that the accuracy of speech production comes from feed forward and feed back control. So you have the feed forward control on the left side of your screen in the brown, that the basal ganglia participate actively in feed-forward control, in directing the initiation of the speech motor control movements. So this feed-forward control of sound production comes mainly from the premotor cortex, input from basal ganglia and cerebellum, and specifically for the speech pathologists in the room, I'm going to use a little jargon now. It's hypothesized that the phonological input from the inferior frontal cortex contributes to the feed-forward system through a repository of phonemic and syllabic motor programs that we learned when we were babbling, syllabic and multisyllabic. This is the automatic part that then gets formulated into words and phrases, so it's inputting linguistic and motor control. Okay, end of the jargon. The basal ganglia is input here is critical for the feed-forward system in planning, initiating, and gating, that is the rhythmicity of the connected speech. Now on the right side of your screen, the feedback control. If the incoming sensory feedback does not fall within a set range of targets, then the error signal is sent from premotor cortex, which then transfers this information to the motor strip. And again, the basal ganglia participate in this feed forward, in the feedback control system also by helping to initiate the modifications. The second part of this model, gradient order directions into the velocities of articulators, begins to discuss how we actually plan motor sequences, all right? That the initiation of speech sounds, the planning of serial sounds begins to account for prosody. This model hypothesizes that the functional role of the basal ganglia in speech production is to select and enable the execution of particular actions from a set of competing alternatives. That is, selecting and sequencing appropriate smaller units, phonemes, syllables, to form larger constructs, words, phrases, sentences. So again, basal ganglia is partaking in initiating and planning the execution of serial sound production. Those of you who are not speech-language pathologists in the room and are wondering why it takes us 2.5 years to get a master's degree, it's because of this kind of stuff. We got to learn all about how to put these sounds and words together, all right? This selection process is called competitive cueing, which is hypothesized to control numerous functions in other motor functions: walking, ambulation, arm swing, eye gaze, reaching, lots of other amazing things the human body does, not just in speaking. So here's just a really simple example. Let's say I want to say the word intent. The phonological, or if you will, linguistic basis for the learning cues of the I phoneme are most appropriate, and that's what gets cued up first, and then that's abandoned, and the next is the sound, et cetera, until I've produced the word intent. And it's hypothesized that the basal ganglia's role is to initiate the correct movements through disinhibition of the correct motor movements and inhibition of the incorrect motor movements. Next slide. Last complicated slide I'm going to show you. Thank you for hanging in so long. This diagram shows in a bit more detail the role of the basal ganglia in speech production. Let's ignore all the detail above in the cerebral cortex and just acknowledge that the speech sounds are combined into words and phrases in complex ways that access many different parts of cerebral cortex, and that the basal ganglia, what you see below in the gray through the thalamus, are involved in planning and initiating of articulatory movements, help direct the range of movements, the velocities, the rates, and the rhythm. So the basal ganglia plays a key role in turning up and turning down cortical activity, and in sequencing these movements in the proper order. So let's summarize everything I've said. I could have gotten to this slide first, right? The basal ganglia, planning and initiation of movement, scaling and maintenance of movement amplitude and force. Let's call that effort. Temporal gating. Let's call that rhythm, prosody. And somatosensory processing, cueing, awareness of gain control. And that when this control is output to automatic function in Parkinson's disease, automatic execution of learned motor plans, that is habitual control, is impaired. Goal-directed execution of adapted motor plans, intentional control, is what the focus is on. All right, so you've all been very eagerly and patiently listening to me, waiting until I get to the good stuff, the speak out and the loud crowd and what all this has to do with that. So we're going to start talking now specifically about speak out and the research looking at speak out. And in order to help you refocus and gain control, and so that you're really ready to listen to this, the speech language pathologists in the room, there's a clump of you here and a clump of you there, right? Okay, so these two clumps of speech pathologists, what I want you to do is I am going to count to 10 by twos. I'm going to count to 10 by twos with intention, with deliberation. I'm going to focus on each syllable, and then I'm going to ask you to do the same. So I'm going to say 2, 4, 6, 8, 10.
2, 4, 6, 8, 10.
Loud crowd, how'd they do? Could they do a little better? Come on, I want to hear it from you. A little better? Okay, speech pathologist with intent. I want you to say this like you own these words. I want you to focus on these words. I want you to throw them over my shoulder. 2, 4, 6, 8, 10.
2, 4, 6, 8, 10.
Yeah? Yeah? Okay, thank you. All right. Welcome to Speak Out. The Speak Out, you will be learning about the Speak Out program, those of you that are not familiar with it yet, over the course of the next couple of days, just to focus a little bit on the verbal cues that are used to scale up effort and goal-directed speech, to overcome the impaired inhibition. These are going to advance one by one. Say it with intent. Say it purposefully. Speak like you're in charge. Be consciously aware of how you're saying every single word. Speak deliberately. Speak with your intentional voice, not your automatic voice. Speak out. Now let's compare these cues that we use in Speak Out with a couple of other approaches, because we know as speech language pathologists, we need a lot of tools in our tool bag, right? So clear speech, which some of you may be familiar with, which is also used with individuals with Parkinson's disease as well as other neuromotor control processes, focuses upon hyperarticulation, and the cues are speak as though your listener is hard of hearing and has to read your lips. Speak twice as clearly as you usually do. Over-enunciate. Put more effort into each word. Boy, this sounds very close to speaking with intent. These are global cues to scale up the articulatory system. The Lee Silverman voice therapy, which has helped so many people and many of you are trained with, focuses, most of the cues focus on think loud, feel the effort, feel as though you are loud. Now, the LSVT focuses, although all of these are global cues, LSVT is focused a little bit more on loudness than anything else. Clear speech, speak out are focused more globally on overall effort, particularly the articulatory subsystem. But as we know as speech-language pathologists, you can't just isolate one without the other, and the research does show that when you scale up one, the rest goes along with it. So as I'm speaking more loudly, more clearly with intent, my arm motions are bigger. Things get scaled up. But nevertheless, focusing more on the articulatory system is a little bit different than just focusing on being louder. A colleague of mine, Chris Jodden, and her, a speech-language pathologist who has done a lot of work in motor speech disorders, and her colleagues published a couple of very interesting studies where they compared clear speech and loud speech. And it wasn't LSVT and intent, it was just clear speech and loud speech in patients, in individuals with healthy neurologic systems and in patients with Parkinson's disease. And what they found is that clear and loud speech both improve intelligibility, the listener's ability to understand you, as well as vowel acoustics, the characteristics of the vowels. But that clear speech yielded a more robust effect than just loudness. And again, I'm not saying that clear speech is equivalent to speak out and loud speech is equivalent to LSVT, but I am highlighting for you the differences between scaling up the articulatory system and just scaling up loudness. Thank you. So, end part of this presentation now, probably the most important, I want to talk to you about the evidence for speak out, because in fact, we practice evidence-based speech therapy. I'm going to talk to you about just a couple of studies that have been done, and then I'm going to talk to you about the study that I'm currently doing. So Chris Watts from Texas Christian University, got that right, conducted a retrospective study of 78 patients that were treated here at Parkinson Voice Project. They all had at least 12 treatment sessions. The outcome measures, how they measured how well the patients did after therapy, looking at intensity from sustained vowel reading and conversation. And they measured they took the data from baseline after the 12th treatment session, after 6 months, and at the 12-month follow-up. What this graph shows on the vertical y-axis is decibels of sound pressure level, that is loudness, intensity. And what the x-axis shows is 4 measurement time points: pre-therapy, post-therapy, immediately, 6-month follow-up, and 12-month follow-up. The blue line, the top line, is vowel, the middle red line is reading aloud, the bottom green line is monologue, and what you see is that pre-therapy, the mean value, the mean minimum intensity level was all quite low, and that immediately post-therapy, there was a significant improvement in the mean values for all 3 speech activities, and that overall, a little dip in the reading, it was maintained at 6 months and 1 year. Statistically, the results were significant, and those little D numbers at the end of the colored lines represent effect sizes. Take my word for it, those are big effects. Okay, so that means not only was it statistically significant, but wow, there was a difference. All right, and there's a lot of statistics that go into that. So Dr. Watts' study found that the vowels increased the most for loudness, reading next, and monologue next. And you're going, well, okay, how does that compare? Well, let's look at neurotypical subjects. So these are all retrospective. I'm going to pull the data from Dr. Ramig's study. And what you'll see now here is the dashed lines, blue dash line vowels, yellow dash line reading, green dash line monologue of neurotypicals. And if you'll see at the starting point, they all spoke louder, and that by the end point, 6 months, they didn't have therapy, but at a timeline 6 months later, wow, look at that. The individuals with Parkinson's disease are not significantly different from the individuals with healthy nervous system. Hoo-yah. Now, you might be noticing that vowels are way up there. Why is that? And that's across all studies. We don't normally go around in life going, ah, right? And that is kind of a training exercise we do. It's a warm-up exercise. And that's kind of a very focused activity. So that's typically going to be much louder. Reading, also a more focused activity, so tends to be a little bit higher. Monologue is probably the closest to actual day-to-day speech. So that's impressive. But retrospective studies are not ideal, as we all know, because you can't control a lot of variables. And so, oh, I forgot that I have this. Okay, so, okay, thank you for reminding me. So I wanted to do one more comparison here, the retrospective data from Dr. Watts' study, now comparing it to individuals from Dr. Ramig's LSVT treatment. So here these dashed lines, blue, red, and green, represent patients with Parkinson's disease who underwent LSVT. The solid lines are from Dr. Watts' retrospective study of Speak Out. And what you'll notice is there is pretty much a similar steepness of curve, that is a similar statistically significant gain from pre-therapy to post-therapy. We didn't have data for going out further than that. So that both therapies look like they're doing really well. The Dr. Ramig's LSVT data, those patients started quieter and they ended quieter. You can't read too much into that because this is comparing a prospective and a retrospective study, and also Dr. Ramig's study was 20 years earlier, so there were probably some differences in instrumentation. All right, but it is interesting, and it does show the similar values of all three. Okay, so small prospective study, Dr. June Levitt from Texas Women's University and her colleagues just recently looked prospectively at 12 adults with Parkinson's disease that were treated here at Parkinson Voice Project. They looked at outcome measures, sustained ah, and vowels extracted from the sentence. The blue spot is on the key again, which I know the non-speech pathologists in the room are going, boy, they think up weird sentences, but that's from a lot of earlier research. And a patient perception scale, voice-related quality of life. And their measurement timetable was looking pre-therapy, post 12 sessions of Speak Out, after 4 sessions of Loud Crowd, and after 8 sessions of Loud Crowd. And what she found was looking at sustained ah and the ah from reading, huge jump in loudness from pre-therapy to post-Speak Out, maintained across Loud Crowd, up 2 sessions. Okay. She also found that looking at the values of the voice range quality of life, that there was a significant increase in individuals' perceptions of the quality of their speech. After Speak Out, maintained across Loud Crowd. And then also very interesting, she looked at the acoustics of the ah. I'm not going to go into exactly what the acoustics are, except to say that what this graph shows is, if you look, for example, first at the blue, what it shows is the acoustic characteristics, the resonant characteristics of e, oo, and ah. And it's the resonant characteristics, the way the vocal tract is shaped, that provides these sounds. And what we want to see is a lot of space between these vowels, because that means the vowels are distinctive. And when vowels are distinctive, the listener can hear the differences clearly. And in order to make the vowels distinctive, you got to open your mouth and articulate clearly. And so the blue vowels are before therapy and the pink-red vowels are after therapy. And what you see is that acoustically, the vowels became more distinct. They were spread out more, which generally translates to greater intelligibility, clearer speech. Getting louder doesn't necessarily make the acoustics clearer. And in fact, a study that was done that I'd mentioned a little bit earlier by Chris Chodden and her colleagues showed that the vowel acoustics in clear speech and intentional speech create a bigger spread of vowels, more distinctive than just being loud. Okay, next slide. So last, I want to just tell you about a large prospective study that we're doing right now. The retrospective study was great. The small prospective study is great. We need a larger study that looks at more outcome measures. So I'm just going to give you a progress report on that because it's ongoing, all right? So the outcome of speak-out therapy for adults with Parkinson's disease, the therapy is all being conducted here at Parkinson Voice Project. The data analysis is all being conducted at my hometown, Lehman College, City University of New York, which helps keep some objectivity. I am not involved at all with the patients or with obtaining the data, just in doing the analysis. So I'm the principal investigator. Jennifer Cody is the PI here locally. Yay, Jennifer, a big shout out to this woman, all right? She's doing an awesome job. Our data technicians currently Sevon and previously Rabab, our neurology consultant, Dr. Chitness, research consultant, Dr. Levitt, and then our training speech pathologists, Pam and Leslie. Thank you so much. Next slide. All right. The funding for this study comes very heavily here from the donors to Parkinson Voice Project. And a huge thank you to the donors for making this study possible, because it would not happen without you. Doing a prospective study is time-intensive and expensive. Jennifer and Sevon and Rabab and the speech pathologists have to do a lot of extra work beyond their therapy. It takes extra personnel. It takes extra time. My grant from National Institutes of Health covers release time for me from teaching a course so that I have time to do the research and that I can hire students as data technicians, and that so I can hire a biostatistician to do the complicated statistics, but it doesn't cover the work here. And I am indebted, and we are indebted, and the field is indebted to the donors here for supporting this study. We have approval, of course, from the IRB, from Institutes for Review of Human Subjects, which any research has to be protected by human subjects review, Western Institutional Review Board for Parkinson Voice Project, my university for my part of the study. So the participant enrollment criteria: diagnosis of idiopathic Parkinson's disease, none of the other concomitant factors, because it gets too hard to tease out the results, all right? These are individuals who are seeking therapy at Parkinson Voice Project. They have to be fluent in English. They have to have cognitive abilities sufficient to participate in the therapy. No history of deep brain stimulation, no history of speech-voice therapy within the past 2 years, and ability to fully commit to the program. And Jennifer and I were talking yesterday, and she said, it's amazing how many patients we have here who have other factors, and not just idiopathic Parkinson's disease, who have had other therapies or other problems, because when you actually start to try to make a very clean study and say, okay, I'm going to look at the effects just with these patients, it's hard to find patients that fit the criteria, but we're doing it. So what's the assessment process? We're assessing individuals who are electing to participate in the study 3 points at baseline, at a minimum of 3 separate days. 3 times they come for the assessment. Then they have the standard 12 sessions of speak out therapy 3 times a week for 4 weeks, sometimes a little additional if the speech pathologist deems it is needed. But the therapy is not changed for this study. And then post-therapy assessment within a week after the 12th session, and then 6 weeks after the 12th session. Why 3 baseline assessments? If we just assess you once before therapy, like the retrospective studies did, and once after therapy, how do we know it's the therapy that made the change? What if the baseline assessment, it was a bad day for you? What if you were at a different cycle in your meds? What if something was going on? So if we do 3 baseline assessments, then we can get a stable baseline, and if we see change after therapy, post-therapy assessment 1 and 2, then we can say, okay, this was probably the therapy. So that's what we're doing. So we're putting in additional assessments, and that's part of the thing that costs money. All right. The outcome measures, we got a lot of outcome measures. Our patients who are participating in the therapy are wonderful because they're doing some extra things for the assessment so that we can get data. So 3 speech tasks, oral reading, monologue, and we're going to be measuring intensity, we're going to be measuring frequency, pitch, we're going to be measuring speaking rate, which hasn't been looked at yet, and sometimes rate can be affected, as the SLPs know. And we're going to be measuring voice quality with something called Kestrel's peak prominence. If you're dying to know what that is while I'm having my Texas-style barbecue, after I have my Texas-style barbecue, you can ask me, okay? It's a numerical measurement from a sentence we were away a year ago, which has been shown to correlate pretty strongly with perception of vocal quality. We're not using the rainbow passage. I know this is sacrilegious. Enough with the rainbow passage. Just say no to the rainbow passage. Every speech pathologist in here can say it in their sleep. The problem with the rainbow passage is it was written in 1960. That's fine. I was around then. It was written in 1960 as a phonetically balanced passage. What does phonetically balanced mean? It means that the phonemes, the sounds in the passage are represented with the equal frequency that they are in everyday speech. Really? I mean, 60 years ago, our speech hasn't changed, so the phonemes are still the same. In 1960, they weren't saying awesome or iPhone, okay? Second of all, it's phonetically balanced across all 3 paragraphs. How many of you even know that there are 2 more paragraphs once you get to the pot of gold at the end of the rainbow? Nobody uses the 3rd paragraph. And it's just a weird paragraph. It really is. It's archaic. But everybody uses it because then you can compare it to others. Well, it's time to stop. So we're using a paragraph modified called the caterpillar passage, which was written specifically to evaluate individuals with motor speech disorders. And it evokes more prosody, more pitch contour. We went to an amusement park. Do you like amusement parks? Well, I sure do. My most memorable moment. And for the SLPs, if you want the citation for that, I'd be happy to give it to you. We stuck in the first sentence. We were away a year ago, which isn't part of that, but then we can measure the voice quality. So we're using the caterpillar passage. We're also assessing patient perception of their voice with the voice-related quality of life, and also another patient self-assessment scale. And the all-important listener perception, enough with the acoustics. What does it sound like, right? So a questionnaire that a significant other, spouse, adult child, best friend, has to fill out before and after therapy about how intelligible the person is, how easy it is to understand them, etc. And then what we're going to be doing, not here, this is going to be done at Lehman when we have all the data, we're going to be randomizing the utterances provided by the speakers at all the time points and having independent listeners listen, and they have to transcribe what they hear. What is the accuracy of the understanding? Because bottom line, we're bringing joy to people's lives because they're better understood. So are they better understood? That's intelligibility. And then we're also going to have these listeners rate how easy is it to understand this person from very easy to very hard. Because those are two separate factors. How accurate is it, but how hard do I have to listen to understand you? Those are two different things. Because if I have to work too hard as a listener, I'm not going to. So we're really excited we're going to have those data, and those will be novel data. Okay, so how many subjects do we need? You notice I haven't talked about that. Most research studies that you read do not do a power analysis. They don't do an analysis that says, statistically, this is how many subjects you have to have in order for your data to be trustworthy. When you've got grants, you got to do that because the people that give you money want to know that. All right. As this is just to update this, because this was as of June 7. I'll tell you how much we need in a minute. I'm going to tell you what we have right now. As of last Friday, we have 25 people that are enrolled. Woohoo, Jennifer and her group. Yay. 23 are retained, 2 withdrew or were lost to follow-up. In any prospective study, you have people that are lost. That's a very low number, though. If it gets to be high, then there's a problem, but that's low. So 23 are retained, 12 have completed the study, and 11 are currently participating. Okay, good. All right. So how many do we need? Well, we have to do something called a power analysis, and I was going to show you complicated graphs, but I thought the Power Rangers picture would be better. Okay? All right. What this analysis says is how big of an effect size are you going to get? Effect size means, wow, that's a big difference, or ooh, that's a little difference between baseline and post-therapy. And how statistically significant is it? So we could take, we all have a feel for what power analysis is. If I came here and presented to you and I said, wow, we did this great study of outcome of speak out and loud crowd. We examined one patient with Parkinson's disease before and after therapy, and he improved a whole lot, so we know speak out is really effective. And you'd be looking at me going, you got a PhD? Like one person? So you intuitively know that that's not a powerful analysis. If I came and said, we're going to do this study and I need all your money because we're going to evaluate every single individual in Texas who has Parkinson's disease in order to figure out if speak out is effective, and you're going, does she really need every single patient to know that? So you know that there's too little and too much, or unnecessarily too much. But what's in the middle there? Okay, well, you pay someone who has a PhD in biostatistics to figure it out for you, okay? Because it's really complicated statistics, all right? And so what you need to specify, or what we're specifying for our power analysis, is that our alpha is set at 0.5. Oh, that's great. I'm so relieved. What is alpha at 0.5? All right, what that means is once I get the data, the probability of finding a significant effect when there really wasn't a significant effect is only 5%. That's really good. You can't get it down to 0. So there's 95% chance that if we find a significant effect, it's real. And we're going to set our power, or our beta, to 0.80, which means that I think I just said it backwards. Let me repeat, because I'm hearing what I said in my brain, and I'm not sure. I think I misspoke. So the alpha is the probability of finding a significant effect when there is none. Okay, I said that. The beta, you know when you stop paying attention to yourself when you're talking? Okay, I got to get focused and intentional here. So the beta is the probability that a significant finding really is significant. And that's frequently set to 80%, but 20% error is too high for us. We're setting it to 0.95, which means that we have a 95% confidence rate that a significant effect really is significant. So the last piece of information the biostatistician has to know to tell us how many subjects we need is, well, how big is your effect? If I'm going to use sustained and you saw those charts, man, you don't need many subjects because we get a big boost in loudness with so we're not using that. I'm interested in monologue. Isn't that the most ecologically valid? Isn't that what would be closest to real conversation? So what we're going to do is based on expertise, other published studies, kind of like what I show you, based on literature, based upon our clinical expertise, and based upon bootstrapping, that is looking at the data we have so far and seeing what the effect is. We then make a decision about how many subjects we need. Next slide. So we're going to do the power analysis based upon the intensity in monologue, the smallest change, the variability of fundamental frequency in monologue, excuse me, I'm using lingo here, the variability of intonation, pitch in monologue, and intelligibility from our listener, that our listeners rate from the oral reading. So we're going to pick the outcomes that are the hardest to achieve. And so what our biostatistician told us is that if all we wanted to do was take a look at intensity, then we would need about 28 individuals to participate. We're almost there. Sit back down, Jennifer, because that's not exactly what we're needing. Okay. Because we don't want to look just at one thing. We're taking people's time, we've taken people's money to run this study. We want to look at a variety of outcome measures, and then we also want to look at interaction effects too. So what about how did the patient's perception of their own speech affect the therapy? How does the intelligibility interact with prosody, with frequency? These are lots of questions as speech-language pathologists we have. So to start looking at some of these more complicated comparisons of the outcome measures, we need a lot more subjects. So we need a total of 38 subjects. We are more than halfway there. Woohoo! I'm so excited. Thank you, donors. Thank you, participants. This study is going to provide some real novel information, not only on the effectiveness of speak out, but on other factors that haven't been looked at yet in Parkinson's disease, and it will be a great launching point to use as research to show to the neurologist, to show to other funding agencies like NIH, to then do more complex, more interesting studies. So you will have to stay tuned for the results. Now, just looking around the room, I was a little nervous about using this picture for the millennials in the room. This is a pre-personal entertainment device called a television set with antenna. These slides will be available to you through email, I believe, and I included some references, and I leave you with one major thought. Thank you so much for listening. I think we have a couple of minutes, if anyone is still awake, if anyone has any questions.
Data acquisition in terms of type of microphone, distance, whether you're doing it in a soundproof room, and also are you using PROT for your analysis and that sort of thing.
Yeah, I left all of those details out. I didn't want to bore a lot of people, but yeah, we are very, very careful about the instrumentation we are using, the digital data recording devices, that we're using external calibration for the intensity. We're maintaining equal distance, mouth to microphone distance, and the specifications we're using are based upon the general recommendations that have been published in the literature for voice and speech research. We are not using acoustically sound-treated booths. The research is being done here, and that we don't have them, and it is impractical. Those are hugely expensive, but the clinicians who are gathering the data are very careful to do it in a quiet environment and keep the noise level low. I am using PROT acoustic analysis software for doing a lot of the analysis, and the data that I've gotten, I've been looking at it very carefully. It is really clean data. They're doing a fabulous job here. Yes? Speak with intent.
I can speak with intent, but I'll use the microphone. Just a very quick question. Are you using a standardized assessment for the sentences, or do you have your own sentences?
When you say standardized assessment, what do you mean
I
standardized?
don't mean a standardized, I'm sorry, like a widely used assessment like an AIDS or French A or anything like that?
No, those really include a lot of non-acoustic analysis data. The analyses that we're doing are highly accepted standardized analyses for research-based speech and motor speech and voice acoustic analyses. So looking at intensity and looking at frequency, and the ways in which we're gaining those data are done according to very standardized means. Is that answering? Oh, okay, so the intelligibility, the standard way in which intelligibility is measured, which is why we're using reading and not monologue, because that would vary too much, is sentences are extracted, and then they're all equalized for loudness level, so that loudness is not the variable there, it's articulatory clarity, and they're surrounded by, milliseconds of silence. They're randomized, and then the listener listens to a specific set of them and has to type what they hear. Okay. Yes?
Thank you. I wanted to ask if you're getting anything about an individual's fitness level, kind of in terms of, high fitness, moderate, low, as well as their something about their socialization level, just in terms of who might be good responders or that.
And there's part of I love that question. That's part of their interaction effect, the interaction effect, which is why we need to get more subjects than just a straight out analysis. I left out little bits of the data. We are obtaining the Hone and Yar scale value of the severity of the disease, and then both the patient self-perception and the significant other perception. There are and as well as the voice-related quality of life, there are questions such as, how much does that person initiate speech, that sort of thing. There isn't a huge focus on socialization. That's one component we don't have, unfortunately.
Hi.
Yeah.
Have you considered translating the material to Spanish? We are 4 here in Puerto Rico from 3 different universities, and our patients speak Spanish.
Si habla con determinación, ¿sí? I feel the same way. I live in the Bronx. I teach in the Bronx, and 90% of our patients, are Spanish speakers. I know that the Speak Out workbook has been translated into Spanish. This first study we're doing is only for English dominant speakers, because the therapy here is all done in English, but a very high priority for me. And in fact, part of my NIH grant funding is to look at Spanish accented speakers of English. Huge, critical. We're going to have a conversation after barbecue. It's very, I mean, Spanish is almost the largest language, the most common language spoken in the United States, not English. And in New York, Spanish is the majority. There's no such thing as a minority anymore. Spanish is it. Yes?
Is the caterpillar passage and the voice-related quality of life, are those available on the internet just by searching?
Absolutely. Those are from articles that have been published in ASHA journals and in this. Yes, yeah. And the full citation is in the references.
Okay, great, thank you.
And if you have trouble getting it, email me and I'll send it to you. Okay. Thank you again. See you at lunch.